Hi. I'm just gonna wait a couple of more minutes to see if we have more people that will attend, and then we will start. Thank you for being here. Appreciate you. Okay. Few more minutes, and then we'll start. Okay. Uh, Good evening, good afternoon. If you're on the East Coast, I just want to say welcome. My name is Irene. I'm a registered nurse. Just want to say that I'm so glad that you are all here, that you're here today. Whether you are a hospice nurse, an LVN, a case manager, or even someone who's leading a team, this training really was made with all of you in mind. Uh, and truly, if you're someone who is tired of pretty much rewriting the same note over and over because your QA nurse keeps sending it back to you, saying that you need to rewrite this, you're missing this element, this is really for you. If you are someone you are that QA nurse that are continuously, reviewing records and you're trying to figure out how I can help provide better feedback, this is also for you. If you are someone who's maybe not in the QA role currently, but you're looking to see how you can jump from your being a field nurse or maybe a manager, and you want to go into actually doing QA full time or maybe even as a consultant like myself, this is definitely for you. So, just to give you a little background about myself, my name is Irene Sursat Joseph. I am a registered nurse. I have been one for many years. My expertise are in hospice and home health, um, QA, quality assurance, pretty much, and anything that deals with compliance that we deal with in hospice and home health. That's pretty much where my expertise are. I started off as a field nurse in hospice and worked my way up all the way to director of compliance and also worked for Joint Commission for several years and then decided to go ahead and pivot into opening up my own consulting agency where I help agencies with QA and with survey, anything compliance that you could ever think in hospice, that's in home health, that's pretty much what I do. And then I decided, why don't I teach others, right? It's one of those you're want to provide you're in the know, you know how to do things. I do a lot of education, a lot of teaching, and I decided, why don't I go ahead and educate, share some of the knowledge that I've gained along the way. So with that, I'm gonna go ahead and share my screen, and we could start. Okay. Okay. So, what are you going to learn today? So, let's talk about everything that you're going to learn here tonight. We don't have, we only have about an hour. I do want to leave some space for us some room for us if you have any questions or if you want to know anything about the services that I offer. I want to leave room for that for us at the end of the session. So, let's talk about what you're gonna walk away with. So, I know that your time is valuable. So first, I want you to leave here feeling that my time here with you was worth it. Because I know what that feels like when feel like you've done those sessions and you walk out and you're like, oh my God, what did I learn from this? But I want you to learn from me. So first, you're going to learn how to think like a Mac or a surveyor in hospice. So we all know that if you're already part of hospice, MAC stands for Medicare Administrative Contractor. So essentially, those are the folks that when hospices sends out claim, they're the one that pretty much deals with the claim, audits the claim, and decide whether this claim needs to be paid or not. So you're not just, we're going to review how to think like one, how to think like a surveyor. Because to be honest, providing good care is not enough. You have to show this good care in your notes. So it's not just, I know I'm providing this amazing care to this patient. You also now have to make sure you're giving proof that you've actually provided this care. The second thing you'll learn is uh, to understand what QA nurse actually do and why agencies need to have someone like this within their organization or hire someone, right? Like myself, if you decide to do the same thing, then you're start providing services as a QA instead of the agency having an in-house QA. So, and what it is about QA, I think sometimes a lot of the nurses always think of QA as policing, right? We're there to police every nurses. That's not what we do. It's all about protecting the agency and the work that all of the work that the nurses have already done. So you're there to make sure that you're catching things that were missed. You're making sure that all the information is valuable, right? The third thing is that you're going to learn the three core skills that every great QA nurse need. So there are different skills that as a QA nurse, for you to be uh, amazing at your job, there are some skills that I definitely do think that a QA nurse needs to have. So I'll break each one of them clearly so that you can really start building that confidence, even if it's your first time thinking about QA. So you don't, whether you have experience or whether you have experience, we're gonna start where you are, right? And then I'll show you the path forward, how you can have a better understanding of what the role is. It's and also knowing when and how to take the next step. And then finally, I'm going to walk you briefly through my own document method that I use and all of my team uses to actually audit records. All right, so let's go ahead and get into it. So, one of the questions that we have is why do most hospices documentation usually fail audits? And why do we all get so nervous when a surveyor comes in? Why does that happen? The reason is because as hospice nurses, even home health nurses, we're thought to document pretty much for our manager because we always think that's who we're documenting for our manager. It may be. And usually it's to make sure the IDG knows what's happening, but we were not trained to write for Mac, right? For the surveyors. We're for CMS. We're not thought to write for them. So when you are writing the documentation, we need to be writing to show that this patient continues to be uh, continues to qualify for hospice. And I think that is something that we usually have not been taught. I know when I started out as a field nurse, I can barely think of even an example of what a note needs to look like. We were just very task driven. It was just like I needed to see a patient, I needed to document on the patient. And that's pretty much what I did my whole nursing career, field nurse career. So the mistake isn't that we don't care. The mistake is that were never told that we needed to spell out clearly in our note that the patient is declining. So we need to be writing about the patient is failing to thrive and how and explain how what do you mean when we say failing to thrive? So and we also needed to understand that if it wasn't documented clearly, uh, easily a surveyor can easily say that's a deficiency, or an auditor can come in and say that's a deficiency, and then that becomes a bigger problem. And with hospice documentation, we're pretty much writing for both, right? Both Medicare, which is the contractor, the MAC, and you're also writing for the surveyors because each one of them review the records very differently. So, as a QA nurse, your job is to make sure that you're keeping an eye on both of these things. So, that is why a lot of those claims get denied. We're taught how to write for our managers. We're not documenting decline. We're not thinking of eligibility, and we're for sure not thinking of justification. And the idea of that you're writing for two set of different eyes, that's not something that we're taught, right? So that's where you yourself as a QA nurse, when you decide to come in and do this field, this is what your job is going to be. You're going to be that person that's going to be reviewing those records and looking at those records in two different perspective and making sure those elements are not missing. Because an auditor or surveyor, what are they looking for? So an auditor is really looking for the PPS. They're looking for fast scores. They're looking for weight trends. They're looking for ADLs. They're looking for changes in condition that's tied into the patient's terminal diagnosis. They're looking for LCD's criteria. Are they being met? And then, of course, they're also looking to see, is your CTI in your face to face, are they matching? Because how many times, if you're a QA nurse or if you're someone who's gone through the records, or even you've been audited and then you get denied and you kind of go delve deeper and you're like, the nurses, the CTI and what's being documented about this patient completely does not match. Doesn't match. So it's like we're looking at two separate patients, two separate disease, two different worlds. So that is what those are the small elements that they're looking for, right? So here's an example, right? And I'm sure you've seen that all the time where it says patient resting comfortably, no complaints, voice continues on current meds. I mean, to anybody else, this looks pretty good. What's wrong with this note? But it doesn't prove anything. It doesn't show decline. It doesn't show eligibility. It does not show justification for hospice. Because hospice, every single time the nurse is writing, it needs to prove that this patient belongs on hospice. And with that, that easily could be a decline. And that also could get you a deficiency with hospice because we're not talking about the plan of care, which we'll get into that a little later. So this is one of the reasons why a lot of the hospice documentation fails audits. So what is your role as a QA nurse? What do QA nurse do? So when people hear QA nurse, they're thinking of someone sitting in a back office with a red pen. With a red pen, if somebody who's just there to just mess people up, mess nurses up. I know that's how I felt, and I could tell you the rage I used to feel when I used to get those email from our Q when I worked for a QA nurse. And then she would send out those emails and would have it in red of all the things I didn't have or should have been documented and didn't document. It was all, and they were all bullet points. So then, we're sitting there, I'm like, oh my God, like first, we don't even understand why we need to do that, right? Just all we see is red and then bullet points. And then now you have to try to figure out and say, you've already seen this patient sometimes a week ago. Sometimes this was a patient that they called you and said, could you go ahead and see this patient for me real quick? And now they're like sending you all kind of things of something like you probably don't even remember who this patient is at this point. But the job of a QA nurse is not to go in with a red pen and show you all the areas that is wrong. The job is all about making sure that we see the big picture. We're there to protect the patient, the nurse, and the agency all at the same time. It is not just about fixing grammar or format. Sometimes format do come into play though, but that's not really what the job of a QA is. We really are there to connect the dots between what is written and what is actually happening in this patient's home. So if it's patient lives at home or patient is in IPU, all of these, this is what the QA nurse does. And one of the things that you're asking yourself is that would this note, right? If someone read this note, would they know what's wrong with this patient? And that's usually what we write. Is would this when we read every question, every time I reviewing a record, the first question that I ask myself, does this patient belong on hospice? Does this record show that this patient belongs on hospice? Would this note make sense to someone who doesn't know this patient at all? Would it make sense? So those are the questions that goes through the mind of a really good QA, right? So the other thing that we do is we review every aspect of the patient's record, and those include the CTI, the face-to-faces. We're making sure the documentation supports the prognosis. Does the physician statement is that strong? Because like if you're a hospice owner here, if you are a CEO and administrator, or if you're part of billing, listen, you know that they will deny your claim because your physician's election, the physician statement it says two lines. Right now, I'm currently working with an agency where we're continuously telling this doctor, you cannot write will likely die. We cannot say likely that it's the patient. We know we don't know, but saying will likely die means that you're not even sure if this patient even belongs on hospice. So those are the things it has to full picture and you have to give data. So we review the visit note also for alignment. Do we have a PPS? Do we have a fast score if it's an Alzheimer's, dementia, senile degen patient? Those things needs to be in there. Does the narrative reflect decline? You're gonna hear me say this all the time. Does it meet LCD criteria? So these are all the things that you're reviewing. You're comparing plan of cares with what actually is happening. And so you're looking to see if there's a plan of care. So we're writing if we could be writing in our narrative, patient is sleeping or agitated. Example. So patient is agitated, only sleeping about 2 hours in the night. So one, right? For sure, we're going to notify the doctor and get an order, right? So that's care for the care plan number one. But number two, now we actually have to write an actual plan of care, which is now going to include goals and interventions of how we're going to help this bring this patient back into a comfort level. So these are all things that you're looking at. You're looking at the intervention. Is it being followed? You're looking at the problem list. The other part that we do is that we're educators. We educate the nurses on how to write better narrative. We're not here to judge. We're here to guide. We're here to help the nurses how to write everything with clarity, with confidence, understanding the diagnosis, understanding why we ask for certain things, why we will say you need to revise or rewrite or ask further questions because maybe they didn't provide enough detail. So we want them to follow up, or could be something that we felt that the doctor needed to be notified, but it wasn't written in there. So we want to make sure we're doing that. We want to keep the agency and survey ready. So these are all the few things that as a nurse, that as a QA nurse that you do. So truly it's not just a job, it's a role of protection. You're there to protect the agency. So why is it so much in demand? It is in demand because denials are rising. The number of hospice claims that are being denied has gone so high. So when a claim gets denied, a lot of money gets lost. Tension rises. We start blaming each other for things. So that is why having a QA or getting QA service is very imperative for all agency. The other thing is that 85% of claims are going into prepayment review. And that is something that is new. Usually it was always the thing, but now 80%, 85% or of claims now that are going out are going into prepayment, which currently I had just helped a couple of agency with this issue. So prepayment means that the agency doesn't get paid until the documentation is reviewed and approved. Right? I want to think about that. Every claim that is sent needs to be reviewed by Medicare, then for them to decide, yes, I'm going to pay for this. But in the meantime, though, if you are a hospice CEO or owner, your cash flow stops because you could have sent out 65 claims. Some of them, not all of them, may be approved because you don't know what was written. But if you have a QA nurse that's continuously reviewing your record, one that you know you can trust anyhow, who has the knowledge, you don't have to worry about those things because you know your claims are gonna go out. And granted, though, not 100% of them will be reviewed, but at least 90% of them will be reviewed and would be approved. So another thing is that agencies have been bleeding money. In the last year alone, 1.4 billion of improper hospice payments were flagged. Not because the care didn't happen, but because they couldn't prove that they did the care, that they provided the care. There are hospices who are, and I know in the news you're hearing a lot of fraud that is happening. Yes, but there's a lot of them too that's also providing proper care, compassionate care to their patient. But then, lack of education, they're smaller hospice. They're trusting because sometimes you have CEOs and owners that really want to do the right thing, but they're trusting that the folks that they're hiring has the knowledge, and then they won't find out until later or something happens, or that's when they're trying to scramble around and realizing, oh my God, this person that I trusted does not have the knowledge I thought she had, right? So these are the things that there's a lot of money that's being misused. CMS is also stepping up. It has added about 30% more medical reviewer to their staff. So they're going to be doing a lot more random checks. They're going to be placing a lot of agencies on 100% review until they say otherwise. So agencies really cannot wing it anymore. You have to have someone that's going to be reviewing your records for you. And the truth is, CMS wants audit notes to be 100% ready every single time, not just once a year, not just for survey. They want every chart, every visit, every discipline. They want that to be 100% ready. So that's what we're dealing with right now. That is why a lot of agency need to either start building a QA programming within their agency, and then or possibly hire company who's already has set up a QA program to help them, or even yourself if you decide to learn more about this and get more skills, for sure start to offer your expertise to a lot of them. So how can you really leverage those skills? So if you're specialized as QA nurse skills, they're highly valuable. It offers diverse path. So you can either work internally in an agency. So if you work, because for me, when I was a field nurse, I was then became a manager, and then from there started to QA, actually just on the side because I just was always someone, again, like I was saying before, the person who knew how to look at different things. Care plan at the time was such a big deal and I can tell you till this day, care plan is still a problem. And I have tried different ways to teach nurses pretty much all the discipline, how to write care plan and when a care plan is triggered. And I think I finally found the formula, but this is not this is not the webinar for that. But I think I finally found the formula for it. But it's still a big issue. It's still something that a lot of nurses are struggling with is how to write proper care plan. So anywho, so because I was that person even from years ago, I understood care plan, understood how to write it, understood when to write it, understood how it gets triggered. So I started out just doing QA and within my organization just reviewing care plan because we had a huge deficiency was just care plan. It was such a big deal and a big to do. So that's how I kind of got into doing QA on just care plan. And from there, I then pretty much got all the way, like I said, to joint commission. But before that, I was a compliance director. But then I could just tell you, but that was just for me on the side on a Saturday reviewing care plan for the agency. Pretty much that's how it started. And then from there, just kind of then went from reviewing plan of care all the way to now me being here, pretty much being here with you. So you could apply all those things directly within your organization or home health agency. You're going to ensure that the compliance, that you're helping improving it, you're checking documentation, and pretty much that's pretty much a very stable employment, direct impact on the agency's success. But you could also start you can become an independent consultant like myself, and where you're offering your audit and documentation services to multiple agencies. And you pretty much can set your own rate, your term, you could start building a team, which is what I did. You build a team and then you have a lot of autonomy and flexibility. And like I said, if you are new at it, if you're a field nurse and you're just thinking about it, this is the time that you start to be part of that committee. QAPI committee, this is the place that a lot of the audits or starts. It's from being part of QAPI. So get yourself involved in that. So let's talk about the blueprint to becoming invaluable. There are three core skills that I believe you need to have to really become a strong QA nurse. And I promise you these skills, you can build them. You can build them even if you have never officially worked in QA before. Um, and a lot of you, I'm 100% sure, already have a version of this already. You just haven't named it yet. So the first one is clinical review lens. This is the first skills that uh, you will need to have is to have the ability to see what's missing, not just what's there, right? The second one is compliance skills. Compliance confidence. This is where you need to understand the standards, You got to be able to connect what's in the notes to what CMS and all of the Mac reviewers are actually expected to see. And then the last but not least is the communication and correction skill. So this one is really where it sets you apart, right? So you have got to have the ability to provide and give feedback without making the nurses, whoever you're providing this feedback to, making them feel small. Because you have to understand that a lot of the nurses, whether it's social worker, chaplain, they're doing the best that they can. They're doing the best that they can. They're doing the best that they can. We were not taught how to write Mac ready notes. So they do not need to be scolded for doing something that didn't know. They did not know. So we're there to guide them. So your job is to guide the nurses. So your role as a QA nurse, again, like we stated before, is to protect the agency. Yes, right? But also to support the team. So when you're providing feedback, the nurses will take it from you if they believe that you know what you're talking about and that the care that you're providing, and then you care that the care that they provided is is valuable and that you care about them. So that's what I'm pretty much going to teach you is how to lead that conversation with lots of clarity and lots of compassion. You're not just there to fix notes, you're there to elevate the whole team. All right, so the first one we're gonna talk about is your clinical review lens. So this is your ability to look at a chart and then see what's missing, not just what's written. It's one thing to read a note and then say, oh, vital signs are there, meds are there, they were given. Check, 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 which is usually how QA is done, but that's not true QA that's going to bring change. So you need to ask in yourself, does this document PPS score matches what's happening at in with this patient? So if you're I'm using terms that I believe that all of you here are aware of if you're hospice. So PPS is a functional status score that we use to determine our level function the patient's functions in that level. So that's what that is. That's what that score stands for. Okay. So when they say patient appears stable, do they explain what is that? What does it mean in terms of function, appetite? Does the CTI reflects the patient's terminal diagnosis? Is it showing actual decline? So when you're reading those notes, so when we talk about clinical lens, review lens, you're reading the note, you're reviewing the note, and there are questions that you're asking yourself along the way. Because it's not just about reading a note of a fellow nurse, right? Because sometimes that happens if you work within the agency and you're reading the note and you're like, oh my God, I feel so bad. I know she's trying her best. But our role shifts. So it doesn't be when we're providing, because sometimes we're afraid of providing feedback because we are thinking the person is gonna feel bad about it or get upset about it. So then that's why sometimes we'll approve documentation just so we don't have to face that confrontation, right? But that's what we talk about communication. There's a way for you to provide that feedback that's more of a teachable moment than showing and pinpointing all the things that you're doing wrong. So you need to review that record as if you were a surveyor, as if you are a Mac auditor, because what you're looking for is evidence, not just effort. Keyword here, you're looking for evidence, not just effort, because in hospice, things get overlooked because you have to understand. And if you've been a field nurse, a lot of us, we're documenting in our car. I live in New York, so some of those houses are hot, especially during the summer. We're sitting on plastic couches in the middle of summer and sometimes in cluttered houses. And that's where we're documenting. You have dogs out barking, families are asking questions. Sometimes the patient sometimes is nonverbal, but who's in the home with the patient? It's their, another elderly person or their husband who's taking care of them. So in between all of that, we're trying to get information, but then that's how things sometimes get overlooked, right? But the chart, even though those you're documenting, I know we know that the nurses in documenting, sometimes horrific settings, the chart still needs to speak clearly and really for the patient and for the agency. So I know sometimes the mind it's always like, oh well, I'm writing this again. I'm writing this. You or we always thinking we're writing for the manager. No, you're not writing for the manager. You're writing to help your patient, advocate for your patient, continuity of care, and then also protecting the agency because we need to show evidence of hospice eligibility every time we document. So the good news is this kind of clinical eye can be trained. You can train yourself once you learn how to see what's missing, the vague phrases, no complaints, the eligibility gaps, the broken links between notes in the care plan and the CTI. After you reviewed them a few times, you can't unsee it. You can't unsee it. Once you open up a record, I could be reviewing a record from just someone just scanning through or just showing like I'll say, wait a minute, stop right there. This Alzheimer's note that I'm reading here does not make any sense. I'm not seeing fast score just from just like I could hone in. So those are all of these are learned skill. So you gotta these are all the ways that you can make sure that you practice it. So it's all about practicing, even in your own note, even in other people's note. I say this even to managers, and I'll say to managers, when a patient calls, right, and you need to review a patient's record, and this is a very helpful tip for any administrative or leader in here. When a manager, I teach where I will tell anyone who opens up a chart, if you're a nurse, or if specifically a manager, and if you're or a DCPS or DPCS, I think we call them sometimes in different states. If you're opening up a record, because whether you're reviewing a patient who made a phone call and you just need to follow up, and I know the first thing you're going to say, well, I don't have time for all of that. The truth is, you do. You do, because when you're opening up the chart, the patient's calling you, you're really kind of skimming through the record and looking to see if, if the patient's like, well, my daughter needs I'm so sorry, I'm the patient's daughter, my dad needs lorazepam and it wasn't sent out. So as a manager, the first thing that I'm thinking is, okay, lorazepam was ordered, fine. I'm looking to see if the medication is there. I'm looking, sometimes it's pharmacy delay things. So, it's pharmacy, you're gonna follow up. You're gonna tell them you're gonna call them back and follow up with pharmacy. It would only take you 2 seconds to see if there's a care plan for that lorazepam. Because to me, that's how I check record. Patient calls for lorazepam because the nurse visited today because of agitation. I'm confirming that the med is on the med profile because I want to make sure before I call pharmacy it was ordered. But the second thing I'm automatically going to do is look and see if there's a care plan. And that is how you catch those things so that it's not when a surveyor walks in months, sometimes years later, is reviewing a record and it's like, well, your patient, you guys are talking about agitation, but there's no care plan for agitation. That could have been caught when that phone call happened. So that's how you start practicing those clinical review lens. The next one is compliance confidence. So, compliance confidence, this one, it changes pretty much everything. This is where you stop guessing yourself and start reviewing documentation with actual purpose. So, compliance confidence means you understand what's expected, not just from the agency, but from a CMS, MAC reviewer, and a surveyor reviewer. So this is not about perfection. It's about knowing the standards, knowing the COPs. So you know exactly when a chart is hitting the mark and when it's at risk. So you need to understand the LCDs. You need to understand what it means when we talk about PPS, fast scores, knowing what a drop really means. We need to understand KPS. We need to understand all of the LCD's criterias or by diagnosis because that's how it's set up. And you will need to know all of them. But here's really these are small things that you'll need to understand, and that's just for hospice eligibility. But you need to understand those tools and you need to know how to use them. So each one of them help tell the story of terminal progression. And these are all evidence that we need to show in our records every single time that the note is being written. So when you're building that compliance confidence, your documentation goes from this sounds so good to this really holds up in audit. This really holds up to anyone that comes in and would ask you any question. And if you become part of that compliance team, when a surveyor questions your record, you'll be able to say, no, 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 if this is what the process is, these are the requirements by CMS, this is what the MAC is asking. So you'll be able to get to that point. So that's where that compliance confidence um, does. So this is what it does. So this is the part where you yourself now have to make sure you need to keep yourself accountable and learn what they are. I could tell you there are a lot of agencies that you would ask their nurses what is an LCD and they wouldn't have a clue what that is. Now they do have different names for them within the agencies, though I'm gonna say, but a lot of nurses have absolutely no idea what that is. So as a QA in honing, getting that compliance confidence, that's the time and the place where you're going to learn when somebody says to you, does this note meets LCD for end stage dementia? You'll know exactly what that means, all the details that's required. Communication skills. I think we said that a few times in here. You need to make sure we know how to communicate and provide feedback. So you can be clinically sharp. You can know all the LCDs and PPS and MAC and all these things. But if you can't give feedback that is clear, respectful, and kind, it will not land. It will not land. It will just go right over everyone's head. And worse, it will not change. It will not lead to change. The goal of a QA nurse is to help with change. So as a QA nurses, we're in a very unique position. We don't just catch mistakes, we'll help grow skills. And that takes a lot of trust. That takes a lot of trust because believe me, most nurses again, I've been saying it, they're doing their best. A lot of them were not trained in survey language or hospice LCDs. I can tell you personally, I was not. As someone who did field nursing for a long time, I had no clue what LCD was. So I know if I didn't know, a lot of folks don't know. Now, granted, though, this is a different time. We're in a different world now. My world, when I was doing nursing years ago, the type of information that we have available to us now was not. Um, so we got to make sure that they're not trying to cut corners. They're just trying to keep their patients safe. They just want to make sure they go, keeping those patients comfortable. Sometimes, like I said, horrible, horrible conditions. So we have to know when we're speaking to them, making sure we're not scolding, we're not sending, emails or corrections in bold red letters or have an attitude in the middle of it. If someone asks you a question and be upset about it, that's not what our role is. It's support. It's to protect the agency, to protect the patient, and to support the nurses. So this is my document method that I use to help with survey. And this document, believe it or not, I created it after years of reviewing hospice charts for many, many years. And I had many, many, many checklists. If you're someone who's ever done QA, you'll probably have a binder of checklists. I only have this. This document framework, I use it to audit. You can use it to audit pretty much every single aspect of hospice, from CTIs to hospital admission notes to IDG notes to face-to-faces to visit notes, from even some parts of it, not all. So you have to remember this is just an acronym. And each acronym stands for different elements in the record. It's a really structured process that I put in place because I wanted to have all of the skills that we spoke about earlier. It's all embedded here. All three core skills, all of the core skills, or right just from using this. It changes your thought process of how you're reviewing and QAing the records and not just using it as a checklist for you to just check mark and check yourself out of QA and have 10,000 binders. That's not what this is. QAing is about thinking. So, the way it's used is that you could see all the letters, and each of the letters stands for something, right? So the letter D, so it's the word document. That's what the word is. And the letter D stand for diagnosis match. And pretty much the reason I did that is because when you're reviewing the record, you need to know what is this patient diagnosis. Because if you do not know what the diagnosis is, how can you review the record and know that the evidence that's needed to show hospice eligibility or terminal diagnosis is there if you do not know what the diagnosis is? So that's the first thing when you're opening up that record. That's the first thing you need to see. The next one is objective decline. We need to see measurable decline. We need to see compare things. We need to know the PPS, is it dropping? We need to see numbers, clear description, not just patient stable, no change. No. And then C stands for CTI and face-to-face support eligibility. So this one, when we're looking at it, we're gonna make sure. So this is also used to check on the CTIs on a face-to-face, but it's also the question, the part where you're gonna ask yourself, does the CTI and face-to-face, do they match? Because sometimes the nurse practitioner doing the face-to-face is saying one thing, the doctor is saying something else, and then the RN is also now saying completely something completely different. So when we're checking out the chart, we need to make sure everyone is on the same page. Is everything flowing and matching? And then U stands for unmet needs documented. This is where you're capturing any new or ongoing care that needs to be captured. So, for example, uh, we have patient who may still need help, who may still have some, symptoms. How many times we review a record that the nurse or they're writing, or even sometimes I've seen social workers write that the patient complained of pain 4 out of 10, and then we all kind of just move away like it's not a problem. Like that is a problem. Unless you have to specifically say patient, its pain is 4 out of 10, which is comfortable as per patient, it's comfortable to the patient, right? So we need to make sure you're even yourself as a QA, making sure that we're meeting the patient's need. We're capturing that. And then the M stands for medication profile, and does it reflect the prognosis? Does it support? And what we want to make sure is that our meds consistent with the hospice goals. Because one of the things that you'll see sometimes is that the nurse would have visited the patient, ordered something, and then there's no documentation of the medication. So this is then forces you to go look and see, to take a look at the medication profile. Um, the next one is E, eligibility aligned with the LCDs. Again, I'm very LCD forward. That talk about LCD, I teach LCDs. You need to understand your LCDs. You need to make sure that it is all of it's aligning here with whatever that's being documented. Whether if it's an Alzheimer's patient, there are specific criteria in the LCDs that we need to make sure that we're documenting against it. We're actually talking about it in our note. Even if it's just a sentence or a word, it needs to be there. And then N stands for narrative, shows progression. Is the patient, is it showing a clear decline? Is it clear? And then T stands for timeliness, and team alignment. So is the note timely? And then are you linking the POC to it? Are we speaking to the doctor? Are we speaking, is the LVN, LPN communicating with the RN case manager if something happens to the patient while they visited the patient? So these are all the things that you need to make sure that as a QA nurse that you are reviewing in the record. So that pretty much sums up everything that how I all of the skills that you need as a QA nurse. Using a proper framework. Now, this is something I created myself, and this is from years of QAing. Now, as you start to hone your skills, you definitely can use your own. But if you would like for me to teach you all of my skills, how to use the document framework, how to apply the document framework if you're already a QA nurse. And if you want to learn more about how to become a QA nurse, I do offer a course that you can do. It's a 4 week course. It's actually I do meet with you live. It's not one of those courses where I don't even want to call it a course. It's really a service. It's truly, that's all that is. It's a service. You are not here because I'm trying to like sell a course. It's really truly a service. I know this is such a big issue that a lot of agencies are dealing with. And if you're someone that you know you just need to validate or hone in into your skills, this is a pretty much a great way that you can get that. It's 4 weeks. It's a live class that you get once a week with me. There's homework. There's homework. We review actual cases. So a lot of case studies. So it's very case study forward. This is not like modules for you to, read. We do a lot of discussion. We talk about different ways of how to kind of hone in those skills. We do a lot. I correct all of those notes with you. I show you. We talk about the LCDs, the fast score, PPS, what they are, what they mean. And then we also have, of course, you're part of a supporting team that you'll have to, you'll communicate with each other. And of course, you'll get a lot of personal knowledge from my own experience, and I'll show you everything that I've done to get me to where I am today. I also offer if we have owner CEOs here, I do offer a completely all done for you QA service where I pretty much everything I just discussed here. This is how we see, we review all of the records, and that's exactly how my team does it. So if you're not ready to either learn it, sit in a class and learn how to do it, and you just want someone to just do it for you, that's what we do too. I do that too. And then this is kind of like to tell you the differences of the training. So I'm gonna leave it at that. And if anybody has any question, I am going to put the link in. This is my QR code. If you scan this, I'm gonna leave it up. Once you scan it, pretty much the replay will be there for you to watch the replay, and then also the link if you want to sign up for the courses there, and any if you wanna consult with me and speak to me for to meet with me first, just to kind of discuss which one will be better for you. You all those links will be there. So I'm gonna go ahead and leave that up for you. So, does anyone have any question? I'll be happy to answer any of your questions that you may have. Anything, maybe you're dealing currently with something in your organization right now that you are kind of thinking about, like, oh my God, how do I deal with it? I'm happy to answer, do a little consult while we're here. Or if you yourself as a QA nurse, different things that had come up, or as a nurse, different situation that has come up and you would want some clarification on it, or I'm happy to answer those too. So the links and everything will, once we're done with the session, it will all be, I'll upload all the links in there. And you'll be able to save my contacts from this QR code too, once you do it. Okay. So thank you so much for being here. I appreciate you all. Thank you. And I will send out all this information later on via an email. If you're interested, I will see you all again. Thank you.